So welcome to the Voices in Health and Wellness podcast, where we explore the people and ideas shaping the future of care. Today, I'm joined by Dr. Dacon Knight, Associate Professor of Medicine at University of Virginia and Medical Director of the UVA Health Ehlers-Danlos Syndrome Center. Dacre has been at the forefront of caring for patients with complex connective tissue disorders, having previously founded the EDS clinic at the Mayo Clinic and now leading one of the most innovative programs in this space. His work combines clinical care, research and emerging technologies, including artificial intelligence, to take one of the biggest challenges in medicine, diagnosing and managing complex chronic illness. So with that, Dacre, I'd love to welcome you to the show. Thank you so much for joining us today.
Thank you. My pleasure to be here.
So perhaps we could start from the top. Could you talk a little bit about your journey into EDS and complex chronic illness?
Yeah, absolutely. It's quite a journey. There's probably got to be a story for everyone who gets into this field, because as we kind of joke about, you don't really find it, it finds you. And that's what happened to me. I had joined Mayo Clinic after military service. Actually, it was 4 years in the Air Force as an internist. And I had joined kind of with this fresh spirited mind of filling any gaps or voids that were needed. And just coincidentally at that time, there was a geneticist who was seeing patients with Ehlers-Danlos syndrome who left Mayo Clinic and created this void, and they needed someone to step up. And I volunteered, thinking that it would be a good niche to grow into and start a career at Mayo Clinic with, and doing research and all the rest. And it's certainly been that. It's been very rewarding. It's been a very upward climb of having to really learn a lot of things that we don't learn in medical school. And it has been very rewarding, because I am thrilled by all the things that I can learn from patients and the research that we can do and the further gaps that we identify that we can fill in the future.
Thank you. And obviously this is quite a narrow specialism. Is there anything in particular that drew you to that and hypermobility disorders?
Well, as an internal medicine physician, we're kind of trained in general practice, really knowing about all the different systems and organs and dysfunction and diseases and things. And we know that, that there is a need for specialization and hyper specialization in today's medicine, because our knowledge has just advanced that far. But we still have a need for GPs and primary care doctors and those with a broad level of understanding to link these organ systems and these functions together, because sometimes they do overlap. And what I've learned in my foray into chronic illness is that there's a often very big missing piece between someone connecting one organ dysfunction to another organ system, between specialties that may not be speaking to each other. They may have some of this silo effect. And so I found that, even as a general practicing internal medicine doctor, to be really in evolving my understanding of how, we can collaborate and coordinate care, but also what that does to serve the benefit of the patient, linking these things together that may not be previously understood.
Got it. Thank you. Always helpful to have that kind of context. So you've built programs at both Mayo Clinic and now UVA. How has your approach to this evolved over time?
Well, it's with just that in mind, of sort of thinking outside the box and knowing that if we kind of focus on one disorder, so let's take Ehlers-Danlos syndromes as an example, as a connective tissue disorder, we're talking about, the sort of scaffolding of the body, the structural, the connective tissue parts, the ligaments, the muscles, the tendons. So taking that and taking what we know about the genetics behind it, but then crossing that over into understanding that this can affect the gastrointestinal system. This can affect pulmonary, neurologic, immune systems, and things like that. So my experience has been that I have to keep an open mind, that the more we learn about one of these areas or one of these conditions, that it certainly does transcend into other organ dysfunction. And so I have found the greatest benefit to my practice is actually having close connections with friends and specialists in other areas that we can, cross ideas over and understand, every different patient, what their needs may be, but also how can we use the tools and expertise of different specialists that, we may not think about initially. So that has been my approach, is often trying to keep an as open mind as possible and out about every individual case that I may see.
Thank you. And so for those less familiar, can you just tell us a little bit more about EDS, just to kind of give clinicians who this is something brand new, what exactly it looks like, and why it's such a challenging condition to diagnose and manage. I know you've alluded to a little bit of that already, but just to give us a bit more picture.
Yeah, as I mentioned, so we're talking about connective tissue disorders, so the inherited type, and there's hundreds of these, of course, but the most common type are the hypermobile types, and we're recognizing those more often now to be more common than previously thought. These are not rare conditions. There are some rare types of connective tissue disorders, of course. There are some subtypes of Ehlers-Danlos syndrome, of which there are 13 subtypes total, and some of them are quite rare and quite severe. The hypermobile type is the most common type of inherited connective tissue disorder, and we recognize that more commonly now. And so what we understand about that is that, well, one, we have connective tissue from our head to our toe, and as I was alluding to earlier, yes, many organ systems can be involved. But it usually presents with hypermobility, hence the name. But this can come in the form of dislocations, subluxations, joint instability. Patients often describe chronic pain or joint pain as the most common presenting complaint. But then by subsequent dysfunction, there can be fatigue and deconditioning and all those things that happen with it. So usually chronic pain, chronic fatigue are top of the list. And then patients sort of navigate their way through, rheumatology, who are specialists in seeing chronic joint pain, and sometimes geneticists who, deal with inherited conditions. But it really is a matter of the clinician and their experience of seeing these things and knowing that there is a pattern in front of them to recognize and make the diagnosis. Often patients go a long time before a diagnosis is accurately made.
I was going to ask you, so how long does it typically take for someone to get a diagnosis in 2026, and how has that picture kind of changed over your clinical experience?
Yeah, well, it is improving, I'm glad to say, and I am holding optimism for the future that it will continue to improve, but still by 2026, we've got a long path to tread. It's roughly at least a decade or more until a patient is receiving a diagnosis, and that was first looked at in some survey studies in the earlier part of the 2000s, and it was around 14 years at that point. Then some of our colleagues at Indiana University had looked at some of their survey studies, and it was still over a decade, and in just the past few years. Some other sites have done some other similar surveys and see that we're really not better than a decade out, and I am hopeful for the future, but we still have a long path to walk.
Where do you see patients typically falling through the cracks, whether it be sort of from a diagnostic angle that you've kind of alluded to, or whether it's aspects of treatment outside of your institutions? Yeah,
well, so related to that long diagnostic odyssey, it usually comes because chronic pain and chronic fatigue are very difficult conditions to address. I mean, there can be so many things that lead into chronic fatigue, right? So it usually starts with casting a very wide net, and that takes time in itself. I mean, we're talking about so many different disease systems and possible disorders that could be causing it. So that does take time. When we get a little bit more narrowed down to connective tissue disorders and hypermobility itself, that does help elucidate a little bit of the diagnosis. But the problem herein is, as I mentioned, it takes really an experienced and trained eye and someone with, also who's thinking outside the box rather than just, typical diagnosis of, chronic fatigue syndrome or fibromyalgia or something like that they notice some other specific patterns, and it could be hypermobility. The problem with the hypermobile type of Ehlers-Danlos syndrome, though, is that we don't know the genetic cause. We don't have a specific genetic test. And often, as we know for chronic pain and chronic joint pain, is that imaging can still be normal despite pain being present. Or even imaging can be misleading. We know if, we do an MRI of someone's spine with chronic back pain over, a high percentage of patients, we're going to find something abnormal. Whether that's something we act on surgically or not is a question. So there's a lot of misleading steps along that path to making a diagnosis. But certainly the testing coming back normal, I would say, is probably the biggest hindrance to patients getting a quicker diagnosis, because as I said, that these tests, imaging, genetic testing, and so forth, can look normal and deceptively so. So it takes a kind of a second order of thinking to make the diagnosis then thereafter.
So in terms of your mission, how are you trying to improve awareness and to reduce that kind of diagnostic window that you talked about earlier? What's your kind of tenets of your mission?
Well, we do collaborate with the Ehlers-Danlos Society, who's doing a lot of fantastic work and getting voice out there amongst the communities and amongst the medical practices and other research organizations, and that's critical. Also, doing the research itself to find, not only portray this long diagnostic odyssey and understand how patients are really being affected by it, but also finding answers of why these things even happen in the first place, which is the first step that we get towards if we ever want to think about coming up with cures or better treatments. We do have treatments, but it is quite involved. It does require multiple disciplines. So I think really, as far as the future goes, getting a more robust medical education into these disorders through medical schools and training programs is going to be the real key for success in the future. So that's part of the work we're doing here at University of Virginia and with other institutions too across the United States.
Thank you. Now, I guess I know every patient is very complex and unique in their way, but what might a typical treatment journey look for someone with this condition at your institution? What are the kind of the essential components of your approach?
Yeah, so usually it like I said, it starts with an initial complaint of chronic pain or chronic fatigue. Those are two of the most common situations, and a patient might start with their primary care doctor and report on this, and there may be some initial imaging and things like that, x-rays taken, some kind of guidance on some conservative measures for pain relief, and topical medications or things like that, or just kind of home remedies, if you will, over-the-counter medications and so forth. The problem is that we know that these are, if it is a structural inherited condition, that this is something that doesn't go away with taking Tylenol for a few weeks, and it can wax and wane depending on someone's activity level, and actually, if the activity level decreases because of the symptoms, then we know that it's a kind of a spiral effect, and it will actually make the symptoms worse. With the deconditioning becomes worse, the joint instability becomes worse, and then the pain becomes worse. So it's kind of an initial intake process. Now, if the clinician who's doing the evaluation is astute enough to ask about other questions and characteristics of features of the pain, like did it come with any accidents or injuries? Are there specific joint features that we're looking for? Is there swelling? Is there tenderness? And no, not really. Not often is that the case in the hypermobility disorders. But as I mentioned, that there can be some joint instability. So it could be subluxations or dislocations and so forth. And so if that clinician is making those observations, then they would refer them to our center. And we do take referrals from outside institutions as well. So and we welcome those as many as we can. We do have a growing waiting list. So my hope for the future is that every academic medical institution is going to have a program for Ehlers-Danlos syndrome that is helpful for patients with these chronic illnesses. But that's generally how it goes at our institution. We do an initial clinical evaluation for every patient in person, and then every person can be different. So tailoring their treatment needs can come next, whether it's physical therapy, occupational therapy being the most common, and then getting them connected to some of our other specialists who help patients with these disorders.
And in terms, are there any sort of typical psychological signatures to this condition, or the mere act of having this condition, it affects psychology in a certain way, and that's something that you and your teams or your multidisciplinary approaches help with?
Yeah, absolutely. So as you can imagine, let's just take, for example, we described that long diagnostic odyssey. Someone's going 10 years with unresolved symptoms. I mean, think about any other medical condition being undiagnosed for, several years, much less 10 years or more. So it's going to be a huge strain on someone mentally. And then, all the stressors that are added to that of, trying to conduct their work and, taking care of families and so forth. So the anxiety just grows. And then it can grow further potentially too if, at best case scenario, they just get misdirection at a clinical visit. At worst case scenario, they're suffering from, clinician induced trauma by, the constant gaslighting and often being told that the condition or symptoms are just in your head. So that's anxiety provoking itself, right? And it really just it's a kind of a snowball effect. So by the time the patients reach that 10-year mark or more, I mean, we certainly have patients who've gone many more than 10 years before a diagnosis is made. That snowball effect has just grown and grown and grown. So it's just even more convoluted problem at that time when it comes to our doorstep. So yeah, I mentioned multidisciplinary approach because there's kind of nutritional needs that need to be balanced into this. But as you're alluding to too, there's certainly mental health support that needs to be added to this because we're now starting to peel back the layers of all the damage that's been done over the preceding years. And so we do work with pain psychologists. We do institute all the things that we can apply that help patients kind of, get back on their feet and, slowly return to achieving full function.
Thank you. So I know you're doing some really exciting work with AI. Do you want to tell us a little about your foray into this field and how you're using it in your work?
Yeah, well, we're looking really for any resource for improvement as we can. I think I've painted the picture that there is a big problem at our hands if there are so many patients out there. These are not actually rare diagnoses, and yet patients are still going decades or more without receiving a diagnosis. Then what can we possibly do to improve on this, right? Any resource that we can find is going to be helpful. So yes, the research I mentioned is very useful, understanding the science behind it. But what are the kind of the tools that we can equip other clinicians with, and even ourselves with, to better understand the conditions? So pattern recognition is one. For understanding the presentation, the clinical presentation, is difficult. And this is not something that's solved just by AI alone. But there are clinical support tools that can be used for making a diagnosis. And what we know about this is that, a physician, has all their wealth of wisdom and all the things that they've learned and seen in the years and what they've been studying in medical school and so forth. But if they've simply never seen patients with these conditions, then they don't really know what to look for. We learn about what we can learn about diseases in medical school, reading our textbooks, but seeing it in clinical practice is how it's finally grounded in our minds and that heuristic that we are able to turn to identify the conditions. But if there is a clinical decision support tool that, even if a clinician has not seen these cases, can pick up on some of the clues. So pattern recognition is one in the clinic. Now, as far as research goes, yes, there are other specific things that we want to use this for. So analyzing some of the clinical, or what we call phenotypic data on our patients, so characteristic features on physical exam, patient-reported symptoms and co-occurring conditions, and how that may relate to their genetic makeup, their genotype. And so those are large data sets, which, as we know, AI is very good at doing. So the larger the data, the better. And we have been accruing the data since we established our clinic at Mayo Clinic in 2019. And we have thousands of patients' samples and reported information on their condition. So we're still growing that, but we've already started developing some of the AI models that we can use to sort of elucidate the signals that we want to correlate between the molecular and the biochemical composition of someone compared to their physical presentation. So that's really a great prospect of how we can use AI in improving on this condition.
Very exciting. And I think you also mentioned when we chatted before about voice signatures and how you're using AI for that. Could you maybe walk us through a little bit about how that even works?
Yeah, well, we can talk about the potential of AI in this field all day because there's really so many gaps still. And there's a lot of potential with these tools, I believe. And there, is yes. So there is a need for improving the diagnosis. So we mentioned clinical decision support, diagnostic tools, and pattern recognition. But as I mentioned earlier too, we don't have a genetic test for the hypermobile type, the most common type of Ehlers-Danlos syndrome. So when it comes to biomarkers and things that we can do, for example, from like a blood sample, we can draw and we can say, oh, your cholesterol is high, right? We've got some pretty good tools for some diseases for as far as biomarkers go. For the hypermobile type of EDS, we really have next to nothing. So again, we're looking at really any resource we can find. We have collaborated with a research group in Toronto who has done some really fantastic work on understanding signatures of diabetes. So this is with my colleague Jan Fawcett at Click Labs, but their work has really moved the understanding of potential tools like machine learning and these biomarkers or anything that we can use for diagnostic understanding. And what they did is they essentially used a voice signature model to identify diabetes. Now, that sounds like perplexing, and it's more involved than the time we have for today. But it's essentially looking at patients who've been affected by high blood sugar, right? And as we know, high blood sugar over an extended period of time can affect the small nerves in our body, the small blood vessels, and affect our kidneys, our eyes, and so forth. But lo and behold, it can also affect voice. And we wouldn't have known that until Jan and his team had tried that study. But what we think about then relating to that type of technological advancement is that there may be a potential role for the same thing, for understanding patterns and voice signatures using large amount of data and some machine learning tools. Can we identify a signal in patients who have connective tissue disorder versus someone who doesn't? I think there's a real biological basis for this. We're just starting that study at Mayo Clinic, but if you think about how the tissue is formed in our body and how there is hypermobility, there's issues with scarring, there's issues with wound healing and things like that. There may very well be some of these differences in vocal signatures too. So that's what we're hoping for. So more to come on that in the future.
Exciting. Lots of excitement. And also, I think you mentioned about digital twins. I don't know if that's something you can speak to as well in a clinical research setting.
Yeah, absolutely. So I have a colleague here at University of Virginia who's done some really exciting work on creating digital twin models for education in the emergency room. There's multiple ways that digital twins can be brought into the field of medicine, and certainly education is a key part of that, and also for research. So if we don't want to put human subjects at risk of outcomes of research or trials and things like that, then creating a digital model of a person with a specific condition is really the next best thing. It's obviously imperfect. It's not as good as the real thing, but the safety measures are quite clear that we're talking about a digital personification of a medical condition rather than a person itself. What they've done in the emergency room tools is to same thing, use these as clinical training for ER doctors and students of emergency medicine. So that you can see what a patient presents like and sort of practice your skills in real time. And that's difficult because getting practice in medicine is it comes with some inherent danger. We always want to have it done in a supervised capacity that it limits the harms and things like that. But there is no doubt that the more trained that someone is, the more experienced they are, the safer they will be. So getting as much training as possible before being in a real life scenario in the emergency ward or wherever is going to be to the benefit of that clinician and to that patient, of course.
And seeing how quickly things develop in the AI space, I mean, how close do you think we are to these tools actually being used in day-to-day care?
Yeah, so it's always a little bit tricky to predict technological advancements, right? I mean, we have self-driving cars, we have, all of these things that just kind of come up all of a sudden. It's kind of like a slow and then suddenly. But I think honestly that I think that's the way it's going to be observed in medicine, is that we're going to kind of be working along, going about our business, doing typical training methods and clinical care, and then we're going to realize that there is this tool that's sitting right in front of us, and I go, oh, shoot, why not? Let's do it. It's better. It's safer. So it's a little bit difficult to say exactly how soon. But I think it's just a matter of a few years that we're going to see real change in the clinical practice of day-to-day care, and I think that is for the better, because I mean, if we're talking about 2026 and we still have conditions going at more than a decade before being diagnosed, then there's a huge space for improvement.
Thank you. So now, thinking about your work from a business operational systems perspective, what's going particularly well for you? What are you most proud of in everything that you do?
Well, reaching the patients who are in need, and as active as we were at Mayo Clinic and seeing a huge influx of patients, when I had relocated to University of Virginia, I realized that we had hardly even scratched the surface. I mean, at Mayo Clinic, we were taking patients from all over the country. We were taking patients internationally as well. But setting up shop here in Virginia, we had already had a patients and waiting list in the hundreds, and that's just continued to grow. And so this kind of relates to my vision of hoping that every academic medical institution in the future will have a center for Ehlers-Danlos syndromes and connective tissue disorders care specifically. And so that has been rewarding to me, is to meet this huge need. There's a huge unmet need for these conditions, and again, I feel like I'm just barely scratching the surface, but constantly I have patients being so grateful, so thankful that we've come here to do this. So we're kind of just reaching our way up the East Coast, but there's still a lot more work to be done.
And on the other side of the coin, what are the challenges or bottlenecks that are most impactful to you in your work right now?
Well, getting the understanding out there, like I said, patients really wouldn't be in these terrible predicaments if there was a diagnosis that was made sooner, if the patterns were recognized earlier on, and the care was provided earlier on, even in childhood potentially, right? So recognizing these conditions that may be affecting children and just kind of teaching them the safe things to do in life, avoid injuries and things like that. Now, it doesn't mean avoid sports or athletics or exercise. Those are all very good things to do if they are done carefully and seeing to it that someone is not doing the wrong type or having repeated injuries. But getting that in place early on, that is a bit of a bottleneck. And so I find it is a little bit more reasonable to try to educate the incoming classes of medical students, from the bottom up, rather than trying to re-educate clinicians from the top down. I mean, yes, we're constantly doing continuing education as clinicians, and we're constantly learning. But the longer the years of practice someone has been practicing, the stronger those biases get in place. And there's a lot of biases in patients with chronic illness. Like I mentioned earlier, it's they're often told it's all on their head, or your testing is normal. Just kind of exercise and it will go away, right? Or just work your way through it. So we need to kind of reframe that thinking, and it is difficult the longer that someone's been practicing.
So with such a specialized population, what tends to break first when demand increases? Now, I know you've been quite proud of the fact you've been able to meet demand, but I guess in other institutions or elsewhere in the country, it doesn't. So what tends to fall apart?
Well, yeah, and we're doing the best we can to meet the demand. We're certainly, our wait list is growing as fast as we can schedule patients in. So we're trying to grow ourselves and are hiring staff as quickly as we can. But I don't think that there's a major breakdown. I think that really what it requires is I hate to use the cliche, but it requires a team effort. Not only that does put multiple disciplines involved, but it requires multiple individuals to be on the same page, to understand that, what we're doing is serving a purpose of a greater good, rather than just, stroking our own egos or just satisfying our own research goals. There is a mission to serve a large number of patients who have previously been underserved. And, having multiple people on that same page, on that same playing field, is a little bit tricky, because, if anyone is kind of, draws doubt or, concern about, the whole process and the whole mission of it, then it can falter pretty easily.
And actually, on the subject of teams, I wanted to ask you, so what's been your approach to building a team that can actually support this level of complexity?
Well, that's a great question, because as I mentioned, we are actively hiring, and so we're interviewing specialists almost weekly now for different positions, and many of them at many different levels of specialty. But seeing as these conditions are not very well taught in medical school, I mean, yes, we get some understanding about pain pathology and mechanisms of pain and things like that, and some autoimmune disease study, but there's not a lot, and a lot of it comes by experience. And so people get wrapped up in this idea that learning something new is scary, or is above their ability. And so what we look for are those that are not like so Pollyannish or so overly confident, but we want to find those people that are motivated and interested in learning. And there are some people that are just more curious than others, right? And so we want to find those people that are curious, because we don't expect everyone to have great expertise in these conditions. I was new to it too myself, just some years ago, and so I know that it is possible to learn and relearn at any stage of life. And so that's what we're looking for, is those that are willing to learn and motivated to do that.
Do you think there's a role for things like group programs, digital tools, or education extending beyond one-to-one consults in this world?
Absolutely. Another excellent question, because that's something that we are actively working on as well. And that is something we did have some success with at Mayo Clinic. And I'll tell you why. The issue at hand is that there is such a huge demand. There is a high volume of patients, and there is in relation to that, a smaller number of healthcare professionals to provide the services needed. Eventually, again, I keep sounding like a broken record on my hope and vision that one day every academic institution will have a place for these patients to go. But in seeing as that there is nothing like that currently at every institution, then we need to do what we can to adapt to the needs of the patients as best as we can. So yes, group programming is kind of the temporary solution for now. I mean, we want to provide as much one-to-one care as we know. We know, educational systems are better provided if they're more focused and individualized. And part of the treatment is education. And that's the big first step in treatment, is education, and letting patients know about what the condition is and how it affects their body, and ultimately how they can become empowered to manage the conditions themselves. So in the case where we have difficulty reaching every single patient individually, we can collectively reach a larger number in a group setting. And so that's the solution that we're embarking on for now.
If I was to give you a magic wand and you could fix one thing in the world in which you work tomorrow, what would that be?
Well, I've got my own biases, because I see these conditions so much and so often. So I would say, let's magically implant the idea of these things being possible in patients with chronic pain and chronic fatigue in every medical learner and aspiring doctor. And so right out of the gates, that they come prepared to meet any patient who comes to them with chronic pain or joint issues, with awareness that these may be present. Now, having said that, I know that's a big ask. So I would say, at the very least, let's keep our medical students and even experienced clinicians motivated to learn and continue to think outside the box, apply the best uses of our technological advances to serve the greater good of our patients, and especially those patients who have gone so long without being diagnosed.
And thinking just ahead to perhaps the next year or so, where would you like your work, your institutions to be in the next 6 to 12 months? Anything on the cards? Anything you're looking forward to?
Yeah, so we'll continue to grow our program, and we'll continue to develop and apply the AI models and tools that we can to serve our patients and to serve the research that's going to benefit patients in the future. And I mean, ultimately, we know that AI should help us do what all good clinicians have always tried to do: to listen carefully, connect the dots of what they see in their clinic, recognize the pattern, and help the patient move forward and function and hope. And I think we're on the path for that. And like I said earlier, I am optimistic about it. We just need to continue on that path.
Thank you. With that, Dacre, I'd love to thank you so much for joining us today. It's been a really interesting conversation. Thank you for educating us more on EDS and connective tissue disorders, and for giving us your valuable insights, and also a sneak preview into the world of AI and how that's going to be impacting things. So thank you so much for joining us. It's been a real pleasure.
My pleasure as well. Thank you so much for allowing me to be here today.